Now, when we talk about HIV, it is a new disease. It's only about 26 years old. Okay, and we know that this disease is spread only by human behavior, whether it in blood transfusion, whether it is sexual behavior, whether we use intravenous drug uses, it is spread by human behavior. Okay, and any behavioral disease has to be modified. We need to bring a change in behavior of the person, and this is where ethics, morals, laws come into play. Other thing that we have is this thing, it has occurred at an era when human rights are more important than community rights. Okay, individual rights are more important. If the same epidemic had occurred somewhere in 16th century, people would have just been caught, isolated, and houses would have been burnt, destroyed, something that happened in the Europe when plague spread in 16th century. Okay, unfortunately or fortunately, HIV has occurred when people have been more conscious of individual and human rights. Other thing that has happened in AIDS, why this HIV has become so important, is the first group of people who are the first group of people who are affected. It is men having sex with men, and that too in America. Though they are a minority of marginalized people, power-wise they are very powerful people. Okay, so they brought into focus the HIV and AIDS. Today it has become very, very important. Now, when we look this, why should we talk about ethics? Okay, the basic reason why ethics becomes important in HIV is we need to protect our interests, that is the medical professional interest, patient interest, as well as that of the society. When you look at the society reacted to this HIV and AIDS epidemic by stigmatization, discrimination, prejudice and isolation, and it is, as time went on, we found that society's interest is best preserved for individual is being integrated, but with the mainstream of the society. And we achieve this by recognizing the rights of the patient and facilitating the same. And we need to consider that HIV of positive person is a part of the solution, not the part of the problem. Now, when we talk about challenges, the public health challenges to prevent the spread of HIV infection. Infected persons' challenges to avert illness, maximize the effectiveness of treatment, and live as long as possible, as productively as possible. Then when you talk about human rights and HIV, human rights protection is important for human dignity. Public their health intentions do not conflict with human rights, and applying human rights, few people are infected with HIV infection, and families can cope with the care of HIV infected patients. Now, when we look at human rights, does it work? Countries that have approached the problem applying human rights have been able to reduce the incidence of HIV. Classical example in the 90s was Australia and England, where they totally applied human rights angle to this problem. And now we talk about less developed countries like Uganda and Cambodia, where the incidence of HIV has come down. Countries that have used isolation methods have spent enormous amount of money, and HIV has been spreading. Classical example is Cuba. Cuban soldiers in 1980s were sent to, there is one of the communist countries which sent soldiers to Africa to fight the different wars that took place. And these Cuban soldiers came back to Cuba in 1985-86. And the test for the HIV infection was available in 86, and Cuba has one of the best health systems in the world. So all these patients, soldiers were tested. Those who were found positive were taken into Havana, kept in isolation. And as 2 years, 3 years went by, at those days we never had treatment for this condition. Patients were given privileges to go home and come back for the weekends. And they found people were escaping, and HIV was spreading faster than that. Other place was Romania, where again HIV has become a major problem because of the isolationist policies that the government has been following. So the basic point that I want to make is human rights approach definitely work when we deal with HIV infection. Now, when we talk about medical ethics, there are 4 principles which again and again I keep repeating: do the best for your patients, do not harm the patient, autonomy, and justice. Now, when you say do the best for your patient, you should not discriminate patients. Okay, that is what we keep talking about. And one of the points that you have to ask question is, does the doctor have a right to choose his patient? Yes or no? Doctor definitely has a right to choose his patients. Okay. The medical council gives you the right to choose patients, and it says it should be without discrimination. Okay. What does it mean by discrimination? Like for example, you are a surgeon, you operate on patients with appendicitis regularly, and there is a patient who comes and says, I am HIV positive, then you say, no, you are HIV positive, I am not going to operate. That is discrimination. Okay. Just because the Indian Medical Council code gives you a right to keep the timings for your this thing. You fix up time that you will see patients between 8 and 12, and if a patient comes at 2 o'clock, you cannot demand that he has to be seen. Okay. So you have the right, but it should not be discriminatory. Okay. So you cannot discriminate based only on the patient. Now there is another problem. This is Dr. Krishna, who is working as a duty medical officer in the district hospital, refuses to see patients if they are HIV positive. Can you do that? No. Okay. And here the reason that we put is, anybody who works in the institution, the institutional ethics governs that person's behavior. Okay, this is very important. You cannot say working in a hospital saying, I don't believe what the institution stands for, I will do whatever I want to do. Okay. So whether you are in government service or private service, institutional ethics becomes supreme over individual ethics. What I mean to say is, like for example, Catholic institutions do not do family planning operations. Tubectomies are not done, abortions are not done. You cannot be a gynecologist saying, no, I don't care for what they say, I will keep on doing tubectomies, I will keep on doing abortions. Okay, I am giving a gross example. There are other things that happen. Like some places they may say, no, unless you pay, you don't treat. You may be working in a situation in a private nursing home. They say, I will put up the thing, let them do whatever they want. That is not there. When you come to a question of do no harm, the important thing that you have to talk about HIV is confidentiality. Okay, and confidentiality has to be maintained. And usually what we have in a HIV setting is a shared confidentiality. What do we mean by shared confidentiality? Okay, when you say shared confidentiality, every member of the team of the hospital shares that confidentiality. It is not only the doctor. The doctor may not tell anybody, but what if the accountant goes and tells, oh, they did a HIV test on him, when I looked at the thing, it is positive. Okay. So it is important that we educate the whole medical community with whom we are working about the importance of maintaining confidentiality. Okay. Then notification of diseases is another place where confidentiality has to be broken, and this is mandated by law. HIV till today is not a notifiable disease. Okay. Now we have here a situation. Raj is a 48-year-old businessman detected to be HIV positive. He is married, has 2 children aged 13 years and 10 years. He requests that his information should not be revealed to anybody. What will you do?
We can counsel Mr. Raju to talk to his wife and discuss the implications of being HIV positive, the virus that can be transmitted.
Why only to the
also.
wife? Why not to his brother?
Why should his brother know?
Why?
Because
the family supports, no? We all live in families, no?
We are not sure whether the family will support.
The person to know is his wife.
Because there is the wife has the risk of getting infected by the husband. So
fine. Okay.
They have to be counseled.
So wife is at a risk, so you would tell them. Okay. Now this is her next case. Muniappa is a truck driver admitted with prolonged fever, diagnosed as HIV positive. His hospital bills are paid by his owner. The patient says that his status should not be revealed to any person other than his wife. His owner meets you and asks for a complete diagnosis. What will you do? Will you tell the owner?
Should not be divulged. No.
He'll say, if you don't tell me the diagnosis, I will not pay the money.
Okay, let him not pay.
You think I'll lose money? Hospital will lose money? Now I'll send another one case, before we talk about this little further. Stan is working in a public sector industry. Factory has an understanding with the hospital that will clear the bills only if a discharge summary is given with all the lab tests. Stan tests positive and requests that his results need not be informed to the factory. What will you do?
Revealing the HIV status to anyone, whether it is the wife or it is anybody else, it is first preparing the patient to reveal their own status to somewhere where they think it is required.
We'll come to that later.
I think that is something which is
okay. I will come to it a little later. Okay. Now see, the difference here is there is a relationship between the employer and the patient, the employer and the hospital. Okay. In the first case, there is no relationship between the employer and the hospital. Here there is a relationship. Okay. So if you have to honor the relationship, you have to write what it is. Okay. Now there are two solutions that you can have. One is ask Stan to pay only for the HIV test, rest of the tests you send as it is. The second thing is in relation to discharge discharge summaries. Okay. Now remember, discharge summaries are a medical document, they are supposed to be confidential. Okay. It has to be shared in relation to medicine, medical thing, and whoever reads the discharge summary also has to maintain the confidentiality. But unfortunately in our situation what happens is the discharge summaries become public documents. Okay. So they not only show the relatives and friends, even the accountants have to will pass the bill only after the discharge summary is given. In this situation, what should we do? These are day-to-day ethical problems. You have to, on one hand you have to tell the employer, on the other hand you have to give a discharge summary. Okay. So here is where we use deception. Okay. You are not telling lies, but you are deceiving a person. You know, there is a difference between deception and telling lies. Telling lies, you would valiantly change something, but here you couch it in such a way that the other person does not understand that you are hiding something. There are two ways of doing it. Use terms which are not normally understandable by lay people. Okay. Instead of saying a human immunodeficiency virus or HIV, you say a retroviral infection. Okay. Unless that person is into medical this thing, he will not know what is retroviral infection is. The second one is to give two discharge summaries, one for public consumption, another for medical practice. Okay. You tell the patient, take this and give it to your accountant, keep this with you when you go to some doctor there, show this. Okay. We have tried both, you know, but you know, patient will confuse which is the one to give, which is not to be given, and this happens. Okay. These are problems that have practical problems. And
why is it that there is more discrimination on HIV than tuberculosis?
Pardon?
Why is it there is more discrimination on HIV patients than tuberculosis patients? Because you can easily get tuberculosis through the person. Why should that?
No, the problem with the HIV is it is the sexual taboo that goes on to it. Okay, it is mainly sex related, and in the beginning it was only a disease which was seen only among men having sex with men, so that there is severe taboo attached because of its sexual connotation and sexual mode of spread.
No, I said, why is it the discrimination is more on HIV than
So we make
TB?
moral judgments on people. This person is a bad person, that's why he has got this disease. Whereas in tuberculosis, we make a moral judgment saying, poor man, he is overcrowded, he is in a place where there is a lot of cough, he is not having food to eat, that's why he has got tuberculosis. That's why you make this distinction. Whereas here, you can, HIV, you make the man as morally bad, morally wrong, he is a sinner. Whereas in tuberculosis, we have pity because he has got it because of the environment that surrounds him. That is the major reason why we have discrimination.
I also had was when you talked in the hospital, we educate our, you know, we maintain the records that the confidentiality is not revealed. Within one clinic setting where a particular HIV positive people are expected to be coming more, okay, there we may reveal, but the moment the person is referred to another clinic for say another department, there maybe HIV is not a major concern and the identification of that person is revealed. How do we handle those kind of cases?
No, I fully agree with you. This is a major problem that happens. How do we handle it in St. John's? Let me tell you. We do not have a separate HIV ward, HIV clinic or anything. They are just seen as any other patient. And all this, at least no, we used to have a program where we used to educate every junior doctor who comes in saying that you know, HIV is confidentiality has to be maintained and things like that, and that tradition continues. So there is not discrimination that takes place. But when you have, like for example, you have a ART center with a big board, voluntary counseling testing center with a big board. The minute a person steps into that place, he may go to see his friend, but he will be branded as HIV positive. So in a way, the medical system itself sort of helps to spread the stigma. Okay, the next case that I have is antenatal mother. Okay, Saroja has been married for the past 9 months. She has problems adjusting with her in-laws. Her husband is very supportive. She is pregnant. During antenatal checkup, she is found to be HIV positive. Husband is also found to be positive. They decide to keep it a secret. Now the mother-in-law is very curious. She wants to know about the tablets that the daughter-in-law is taking, and she also wants to know if her daughter-in-law has a serious disease because she had some skin rash 3 months after the marriage. What will you do? See, what I am trying to bring out is it's not clear-cut black and white situations that you will face, and this is the major issue that we have when we deal with antenatal mothers. Okay. Now then next we have another one case is Ramappa, 64 years old with a history of loose stools for 2 months duration. Son-in-law says that the patient is HIV positive and requests you not to tell the patient. What will you do?
He has to be informed about it. But of course, following the NACO guidelines of this
64-year-old man, he's finished his life, you know, he's a retired.
How can he
play with grandparents, children?
We cannot make a value judgment.
I'm sorry, I'm
on
also
this.
going to that level. I forgot about that.
We cannot pass a value judgment on the age of a person. This person, before we get him tested, he has to be given
Counseling.
We have to be given counseling, pre-test counseling after doing the test. And
Madam, you're not a medical practitioner, no?
No, I'm not.
Okay, that's why you do not know. In most of the time, the testing is done without counseling.
But we can't do it. HIV testing cannot be done without pre-test and pre-test
Where is
counseling.
the rule? Where is the rule?
Yeah, it is a rule.
Where is the rule?
It's a.
Where is the rule? Show me.
It's.
Informed consent is there. Okay, I'll come to that again. Okay, just keep this. Please park it somewhere. We'll come to that again and we'll talk about it. Okay. Okay. So when can this confidentiality broken? It can only be broken when there is a risk of infecting another person. Okay. And now we come to a question of autonomy, and here in autonomy we talk about consent, and here we always balance public health interests versus the freedom of the individual. Okay. It is not always that the freedom of individual is the most supreme thing. There are situations where public health is more important than the freedom of the individual. Okay. So it is not clear cut right this thing. Like for example, a needle stick injury. Okay, and you do not know the status of the patient, but here healthcare workers' life is in danger, and you know if you give prophylaxis for him or her, she will be protected from the infection. And here is one place where even if the patient refuses to get his HIV status tested, you will go ahead and test him, because your interest of the healthcare worker is more important than protecting the interest of the patient. Okay. Now, whenever we talk about this, the basic principle is treatment should produce an outcome that is beneficial to the society as well as to the individual. Sorry for that word. Okay. And here again the question of treatment or isolation comes in. And today nobody talks of isolating HIV infected persons, because there is enough epidemiological evidence to show it does not work. Okay. Now, when we talk about consent is essential for testing. Okay. Now, can mandatory testing be done? No? Okay. Pardon? No. There are few this thing where we do mandatory testing, that is blood transfusion. Okay. Here again the public interest is more important than the individual. And remember, when blood transfusion, a unit of blood is tested, not the donor. Okay. In blood transfusion, even if you have a single test positive, patient is discarded. Okay. Then the second thing that you have is foreigners. Anybody who stays in India for more than 6 months need to have an HIV test done. Is that rational? The reason why we do is tit for tat. Okay. When we go, we get tested. So when they come, we test them. Then the third thing that we have is pre-employment. Okay. I'll talk about, and the only place where pre-employment testing is done is in the army, and unfortunately that slide is little back. So I'll tell you why in the army you do a pre-employment testing, whereas in others you do not do pre-employment testing. Now when we talk about this thing, testing becomes an important part of consent. And now I'm going to talk about controversial topics. One is antenatal testing. prevention of mother to child transmission is a medical possibility, and there is a very simple intervention which is very good for the child, bad for the mother. It costs only 56 rupees to apply that intervention. So there is a place and for doing mandatory antenatal testing. Okay. Because in the 10 years ago, 15 years ago, there was nothing you could offer if you detected a person as HIV positive pregnant woman. But today you have very simple methods that can be used, drugs can be used, a single dose at the time of delivery and a single dose to the baby after 72 hours prevents the infection to less than 2%. Okay. So here there is a place for doing mandatory testing. And when this concept came about in obstetrics, when it became a mandatory form of testing, there is a whole, this happened somewhere around 95, 96, when 94 was the first time it came about, and 95, 96 was the time when in America they started testing mothers antenatally for HIV testing, okay, without the big thing that goes on. So from there came the concept of opt-out testing in pregnancy. Okay. Normally, let me explain what I mean by this opt-out technique or opt-in technique. You see, the way you ask the question, I say, I am going to do a HIV test. Okay. If you give me permission, I will do the HIV test. This is one situation. Another situation is, I am going to do a HIV test. If you object to the test, I will not do the test. Okay. So the first one is known as opt-in, because you are making them inclusive. Opt-out is, you are telling them that you are going to do the test, and if you refuse, then I will not do the test. Okay. So in pregnancy, what we are supposed to have is an opt-out testing, where pregnant women are told that HIV test is being done. If you do not want, we will not do it. And almost 99% of the women will agree for HIV testing. Okay. And it also, this thing, it sort of, we will talk about the last part where we talk about exceptionalism of HIV. This normalizes HIV as part of a disease that is there common in the thing. Here is a case. Rajshekhar is undergoing hernia operation. Surgeon orders a pre-op HIV test. He is afraid of getting infected and he routinely tests his patients before surgery. Is he justified? So you are worried that you will get an accidental injury while handling patients. Okay. Now I will give you another case and you tell me what are the things that happens. Here is Dr. Shyam, passed his MCH exam and joined St. John's cardiothoracic unit, assisted in open heart surgery during the day. He accepted to monitor the patient post-operatively. Now, when you are young, you are enthusiastic to impress the boss so that he will get cutting chances. Okay. At 12 midnight, he received a call from the emergency department, and there was Mr. Y, who came with a midnight with a history of difficulty to swallow, pain in the chest for 2 months duration, fever on and off. Chest X-ray revealed widening of the mediastinum. CT scan showed there was collection as well as a foreign body in the mediastinum. Dr. Shyam was called. He posted the patient for immediate thoracotomy and exploration. Patient was taken up for surgery at 2 a.m. While exploring the mediastinum, he nicked the hand of the assistant. He also had a cut in his glove as well as 2 puncture marks. Can you identify the factors that led to this disaster? He is just learning. Yeah. So I told you on day 1 itself, you go through a learning curve. So he is probably from MCH newly come, so you may not have the skill. He is tired. He is not able to give his concentration or have his physical abilities. Anything else? Why should the assistant's hand should be cut? You know, you have to retract. Okay, instead of using a retractor, you put your hands like this, bravely and stand. This happens. Pass the knife in a tray so that these are simple things that happen. Okay. Now, the other thing that happens is also, those of you are medical, this thing, when you open the thorax, it's a dark area. So visibility is poor. Because the visibility is poor, you are more likely to cut or make mistakes. Okay. When accidents are totally on the part of the surgeon, what do we achieve by testing the patient? Okay. This is the basis behind what we talk about testing before surgery. It doesn't make any sense. Okay. There is also another one thing which is known as window period, where the test is negative, patient is infected. That is very, very rare thing that can happen. And if the patient is in the window period, this again will be missed. Okay. So these are the usual things that happen for accidents. So testing the patient is not answer. Answer is to improve your skill. And if you go and tell any surgeon this, they'll shoot me. They say, you're talking rubbish. Okay. Then recently, 2006, 2007, there has been change in the testing policy all over the world. Okay. And this is mainly because of what has happened. Is you can see the number of patients who are tested positive 1 year before they turn into AIDS. That means if you look at the history of AIDS, there is a asymptomatic period which may be anywhere between 5 to 10 years. Okay. And they become symptomatic, they develop AIDS. So in the 5 to 10 years, this person has been spreading the infection. The last 1 year, they come to know they are HIV positive. Okay. So in 1992, it was 51% of people were diagnosed as HIV positive 1 year before they developed AIDS, and in 2004, it is 39%. So there has been a huge chance that there have been transmission taking place, and only when they land up, 87% of the infections are detected at the time of getting into a medical system. Okay. So this puts to rest our concept of voluntary counseling, where people will come from communities, say I am at risk, so test my blood, I am HIV positive. And this is not only true in America, it is also true very much in Karnataka. This is statistics for Karnataka. 2.1 crore sexually active population in the state. Only about 1 lakh people accessed VCTCs in the last 3 years. Okay. 1.3 sexually active population in the state utilized the VCTC centers in the state. So what is happening now is our testing centers are not serving the purpose for which we have started it. Okay. So the government, instead of taking positive action, they just changed the name. Instead of voluntary counseling and testing test centers, they made it integrated testing centers, so that even the pregnant women who had antenatal clinic will attend these centers. That is not going to solve the problem that we have. So now what even the WHO has recommended in 2000 is what is known as provider initiated testing, because most of the testing occurs in a hospital settings. Now they talk about that we actively advocate people to be tested for HIV. Okay. So it also says that you have to have basic conditions of confidentiality, consent must be there, and you should have both this thing, informed consent has to be taken, and we need to have antiretroviral services also to be provided. So you have to give minimum information that is provided, the clinical benefit and the prevention benefits of testing, right to refuse, follow-up services that will be offered. In the positive result, patient will be given post-test counseling. Okay. As it is, the testing is abused in medical settings, and if this becomes, it will become much more easy for doctors to go about as doing these tests without even asking patients. That's my biggest worry.
But the question is, what reaches the larger people is the
larger people even today is hospital setting. You have to accept it. NGOs will protest.
Rural and the
yes, everywhere it is the hospital setting. NGOs will get upset because their bread and butter is gone. Okay, but this is a reality. 90% of the patients who come tested with us are tested because of a medical problem. Less than 1% people go because they feel that they are at risk for getting the infection. Okay, this is practical, and you can ask people who are working in the medical field. This is what happens in practice. Okay, now next thing that we talk about is justice. Justice is when there is a struggle for scarce resources, and when there is life is brief, is what we talk about then. It is unacceptable for anyone to suffer or die from lack of access to adequate or appropriate treatment and care. When you have no money, philosophy comes to play. Okay. And here also you must see the choice of words. Lack of access, adequate or appropriate treatment to care. It does not say that we will provide access, we will provide this thing. Okay. Now this becomes a very important thing, is equitable access. Equitable access, that means the treatment that is available for other people also must be available for people with HIV and AIDS. And when you say treatment, it is not just the treatment of the drugs. Always people talk about drugs. It's the whole infrastructure that goes with it. There is no point giving drugs to a starving patient. He requires nutrition more than drugs. So it's a whole gamut thing that comes about when we talk about equitable access. Now, NACO policy was in 2002. That policy has not been changed. even after NACP3 has come into effect. Okay, it is assumed that NACP3 will reflect this policy and policy will evolve from NACP3. Okay, adequate equitable provision of healthcare to HIV infected people, improve services for the care of people living with AIDS in terms of services both in hospitals as well as home throughout the country healthcare system. And we talked no individual should undergo mandatory testing. This is the NACO policy. Government recognizes that without protection of human rights of people who are vulnerable and affected with HIV and AIDS, the response to HIV and AIDS epidemic will remain improper. And the government decided to do a lot of things. They wanted to reform criminal law. Okay, and there is a lot of controversy of Prevention of Immoral Traffic Act. Okay, the point there is the Immoral Traffic Act, the prevention. Now the onus is the clients will be punished. Okay, if you are punishing the clients, the workers will have no people coming to them. Okay, how do you balance this? On one hand, you want to make sex work safe. On the other hand, you are doing things all that to reduce the amount of sex work in the community. Okay, strengthening anti-discrimination laws, ensure availability of quality care, educated HIV infected on rights, educate the community to change its behavior, share knowledge with UNAIDS. These are the things that they said they will do. Social and economic well-being of HIV infected patients, protection of their rights to privacy and other human rights, adequate drugs for treatment of opportunistic infections. In 2002 policy, they said antiretroviral drug will not be supported by government because of its prohibitive cost, indefinite treatment period, cost of monitoring the therapy. Government will reduce customs and excise duties on the drugs. The government will review the policy. And the government reviewed the policy again in 2003, and they said at the free of cost only if the government institution is in a phased manner. Institutions in 6 high prevalence states were included, and now slowly the number of testing institutions are increasing. And according to the Government of India regulations, ART will be supplied to seropositive mothers who have participated in PMTCT program, seropositive children, people with AIDS who seek treatment in government hospitals. Now it is slowly being modified that it will change and it will become common for everybody. Okay, now the question that you ask is it right to give medicine first to seropositive mothers? Why not seropositive fathers?
At PPT-CT center, mother can be regularly monitored.
No, after she delivers, she has to go to the ART center.
Then she has to go to ART center.
Because if you treat the mother and mother lives longer, the child will have a better care. If you treat the father and don't treat the mother, father may marry and the child will be left in the lurch. So we have little money, so we have to make the best use of the money. So that the government decided it will treat mothers so that there will be one living parent who will take care of the child for a longer period of time. Okay, I think I'll stop here.